Well, good evening. I appreciate everyone coming. It's a small crowd today, but that makes it a little more personal, and we get some more time for some questions. So I've been asked to talk about, some new technology we have here at Montefiore St. Luke's, presumably the ROSA robot, okay? I'm just gonna do a brief introduction. It's called the aging athlete, but this doesn't mean you had to be an athlete. It's the aging everyone. And a look into what happens with our old injuries, all the little things that we blew off when we were youngsters and now are hurting, i.e. pain and soreness and stiffness. My name is Ken Rauschenbach. I'm an orthopedic surgeon. I've been in the area for about 25 years. I work at Orthopedic Associates of Dutchess County and here at Montefiore St. Luke's. All right, so acute injuries in the aging athlete. When we go out, whether it be an athletic event, doing the lawn, lifting a shovel, whatever we have to do around the house, simple vacuuming, you tweak that shoulder, you tweak your knee. The basics are all still the same. Rest, ice, elevation, and compression. As we get older, I always include an anti-inflammatory as long as you can take it, whether you're on blood thinners or gastrointestinal issues. But, you tweak your back, you tweak your knee, this is the mainstay of the basic treatment before you consider coming to see the doctor. Should I go to the ER? Everyone says, it hurts, It depends on the type and the severity of the trauma involved. You reach down and you grab something heavy, you have a little twinge in your shoulder, don't rush to the ER, spend 6 hours there, and they're gonna tell you to take some Motrin and come see me tomorrow. So think about it, if it's horrific pain, of course, you're always safer to go to the emergency room. Try that basic treatment, the RICE, as well as the anti-inflammatory. Depending on what your pre-level injury or fitness was, if you are pretty sedentary and you did something, you might be a little more worried that you did some real damage. If you're in pretty good shape and you just kind of overdid it, I think that giving it a couple days, some anti-inflammatories, some rest and ice is the best way to go. Again, if you have a large amount of swelling, black and blue, malalignment, deformity, you can't bear any weight, of course, go right to the emergency room. So after all of these injuries, what happens to us? Okay, we spend our lives after that old football injury in high school or, running injury on the playground. And these we recover from them, but they do some damage to the underlying joint surfaces. And this results in what we call post-traumatic arthritis, okay? It's the wear and tear of life along with the cumulative injuries we sustain that causes this effect, It's like the treads on the tire, you get your 40,000 miles and they start to wear out. Although the tire still spins and works, not quite as good as it used to be. What are the signs of arthritis? Pain, stiffness, we get limited range of motion. We start to have deformity. You see people walking around with their bow legs or malalignment. This comes from that loss of cartilage and an uneven distribution, which changes the contour of our bodies and again, changes our function. So, structure governs function. So it's important to look at. Instability, when we get really further along in the problem, it starts to buckle, give out, and gives us lots of difficulty. All of these things can lead to grinding and crepitus, and simple activities of daily living become problematic. Getting through your supermarket run without having to sit down and take a nap for an hour when you get home. How do we treat arthritis? The standard algorithm that we all do is, weight loss is important. Activity modification, okay, meaning, no high impact activities, running, jumping, etc. Become the more sedentary activities, but we still want to be active and keep our muscles going. Physical therapy is an option in order to strengthen you up, and the better the muscle strength is, the better the support on the joints are. Then we go to anti-inflammatory medication. We can start with the Advil or Aleve, and then if it gets worse, you come see the doctor, and there's about 40 different prescription anti-inflammatories. So not everyone works for every person, so we try a variety of them. And then injections, okay? There's two types of main injections. There's cortisone, which is an anti-inflammatory. And then there's the new, in quotes, gel injections, which are these, it's called viscosupplementation. It's a hyaluronic acid that we inject into the joints, and the idea is to bathe the articular surface in the nutrients it needs in order for the cartilage to prevent further degeneration and wear. Joint replacement, that's the final stage. That's when nothing else has worked. We've exhausted all our activities, we've lost our weight, and we're in pain every day. You know, when we can't walk a block or difficulty doing anything around the house, we're ready for knee, hip, or shoulder replacement, depending on the joint. Over 1 million were performed in 2020. That's a huge number. 600,000 total hips and over 50,000 total shoulders. So people are living longer, people are more active, people want to be out of pain and perform their activities, whether it be golf, simply walking, or more aggressive activities. So joint replacement, the idea is to get rid of that uneven articular surface, you know, say it's like sandpaper rubbing together, and give you a new smooth bearing component. You know, we see the picture on the left there, or my left, is the osteoarthritic knee. You can see the joint space is worn down along that medial aspect, and the lateral side still has some space. That causes the knee to bow, malalignment, and then increasing pain. After we've tried the medicine, the therapy, that's what a knee replacement looks like, okay? This is the same for the total hip, the normal but arthritic hip on the right, and the one that's already been replaced with a new bearing surface, and that's a ball and socket joint. And then the shoulder, very similar. We replace that surface so that you have a smooth articulation, and that'll take away the pain. So what's the important things to make these last? We always talk about, when should I have my hip or knee or shoulder replaced? It comes down to longevity of the prosthetic, okay? The earlier we get it done, the more it's going to wear, then the higher chance it's not going to last our lifetime. Typically, we talk about shoulders lasting 10 to 15 years, knees are about 15 to 20, and hips are 20 plus. The most important thing is getting that longevity, is getting the alignment and position of those prosthetic devices as perfect as possible. Again, I'll go back to the tire scenario. You know, you can go get brand new tires. If you don't get them balanced and aligned, they're going to wear out very quickly. So what do we do to make these as balanced and aligned as possible? We've been working on this over the 30 years. I've been involved in, you know, joint replacement's been around for about 50 years. And each year we get a little better, you know, better components, better materials. The plastics we use have made the longevity slowly but surely increase, which is what we really need to keep doing. So I've been asked to talk about robotic joint replacement. So we've had multiple inclinations over the last 20 years on how to get the best position of these components, because we know, like I said before, structure governs function. That we get them balanced and aligned, like the tire on your car, they're going to perform better, they're going to last longer, and we're going to get the best possible result. So these are the components. You know, it looks, people hear, what is a robot? Why do I need a robotic replacement? What does the robot do? This isn't like a sci-fi movie where the droid robot from Star Wars comes in and knocks me out of the way and does the replacement. The idea of the robot is to make the cuts as precise as possible and allow us to preoperatively plan as well as intraoperatively adjust any issues we have during the surgical intervention, okay? The typical total knee used to be performed with jigs that we based on our anatomic alignment. So the anatomy is a little different on every person. A 5-foot woman and a 6'4" man have different positions and alignments. We have to make those adjustments, which were kind of, you know, gross adjustments that we made by our experience and our time doing this. And, you know, these computers / robots help us make those adjustments beforehand, make our cuts more precise, and hopefully increase the longevity of the joint replacement. So this is the operating room setup. You know, here it doesn't look like there's any room for the surgeons. These aren't right on top of the bed like that, but the idea is the same, where we have these robotic arm on the right and then this camera on the left that picks up the motions of the leg, saves the points, and does our planning. So, well, once we open up the knee, we have this planning screen and we take these points, we put a little pointer where that yellow dot is, and then we follow all of those prompts on the left, and it essentially makes a 3D model instantaneously of that person's knee in real time, okay? By doing that, we know exactly what our angles are, our positions are, and we can plan our cuts. So this is what the planning screen looks like. By using those cuts, we have a preloaded X-ray, and it shows what our gaps are, our balancing is, and we can make adjustments by rotating it a little bit, taking a little bit more bone, lifting it a little bit to make the flexion and the extension gaps equal so that we get the best possible result. We could never do this before, and these minor tweaks make a big difference, hopefully in longevity of the knee. So we can get an extra year or two out of it, you know, it's well worth it. The way we set this up we use these special arrays. You can see those blue things with the white dots on them. So the incision here, obviously this is a model, is made. We put 2 little pins in the tibia, which is the lower bone, and then 2 in the femur, and attach these arrays. That camera looks at these positions, and we bring the leg through a range of motion. And by saving those points, we know where the knee is in space at all times. The computer knows and the robot knows. We then take that robot, and using that preoperative screen, the robot brings that little cutting block in there. The surgeon guides it into place, and we pin it into position. We confirm that it's just about perfect, and then we make those cuts. This allows us to guarantee that the cuts that we preoperatively planned are the cuts we're making intraoperatively, and that we get what we planned for. So what does the robot do? It allows registration, planning, and creates essentially a 3-dimensional model in real time. We use specific downloaded X-ray information along with the real-time points taken, and this allowed us to make those both preoperative and intraoperative adjustments to get perfectly balanced gaps. So with a knee at 90 degrees and a knee in full extension, if those gaps are even, we get a nice smooth transition, and that is going to lead to, you know, better longevity, less wear on the components, and hopefully, again, make these knees last longer. So does a robot do surgery on me? No, I want this not to be misconceived that, again, no, the robot at no point does anything that I don't want it to do, okay? And really, it never, ever makes a cut on you. I do everything with my own hand. The only thing it does is align that little cutting block, which I use to make those cuts, and I know they're going to be, and I'm able to verify and check those cuts right on the robot because it's saving this all in real time. So I will be doing all the cuts. I will be doing the opening and closing of the wounds. The robot's there just to guide the cutting block. If at any point something happens, the robot shuts down, it's not a big deal. We've been doing this for years and years and years without it. We remove those little arrays and we proceed with the standard knee replacement with very, very, very good results. All right. So what are the benefits of robot total joint? So research tells us, like I mentioned before, that the better the alignment, the better the balancing, the longer the longevity of the joint is going to be. So it's going to last longer. And that's our goal. People are getting joint replacement at earlier age. You know, people have the ability, want to be active and involved in sports and different activities for longer periods of time. And honestly, people are living much longer in the United States. I mean, in the last 20 years, women in the United States are living into their mid-90s, men into their high 80s, which, you know, is amazing. And living means being active, being able to do things, not just breathing. So total joint replacement allows us to do those, be active, and be pain-free, essentially, or limited pain, let's put it that way. You know, how much will the robot help in the long term? You know, we can do all the experiments in the lab we want, but when it comes down to it, it's going to take time to definitely know if these are going to give us that extra 15, 5 years, 10 years, whatever. But we know that all the research shows us the better we make the cuts, the more precise everything is, the more likely it is to last.